Thank you very much, Dr. Saad, for a very informative lecture. Our next guest speaker who made it, lucky, Professor Shahzada Ahmed is the head of the otolaryngology head and neck unit at the University Hospital of Birmingham, and today he's going to lecture us on nasal imaging, the surgeon's roadmap.
Nasal imaging, surgeon's roadmap. A few slides, or a slide on plain films, then I'm going to talk about CT mainly, a little bit about MRI, and maybe one or two cases within there. So to start off with, quite simply, for sinuses there is no indication for plain films, and if we want to investigate sinonasal pathology, we should go straight to CT. When we are looking at CT, we want to look at multiplanar reconstruction, and we want to try and look at scans all the time in coronal, sagittal and axial plane, and more and more we're certainly using cone beam CT, and if we look at cone beam scanners, we've got one sitting in our outpatient department. We get excellent bone resolution, which is usually what we want for CT, with less radiation. So there's a good governance argument to use cone beam if you can. When it comes to looking at your imaging, most of us will use a DICOM viewer, and these are two DICOM viewers that are both open access and freely available. I've moved to Horoz, but they're both very similar and are available open access that are there. So as far as the anatomy, we've got to study the important anatomy. The anatomy of the nose, the paranasal sinuses, but once we start looking at it in detail and in the literature, we can get confused because there's confusion with terminology. In 2014, there was a European position paper looking at the terminology of the internal nose and paranasal sinuses, and if you're coming up to exams, it's useful to pick that up and have a look at it. And again, this is available in the Rhinology journal as an open access journal. But the frontal sinus is different, and within this classification, some of the changes that are recommended can be confusing. So within the frontal sinus, we've got the Kuhn classification. We've also got what might be considered for most of us more useful, which Professor Wohlmold published in 2016, which is the International Frontal Sinus Anatomy Classification, which is much more applied, and it tries to get you to think about where the frontal sinus drainage pathway is. So what you want to do is pick up a classification and learn it and understand it. Because when you're talking about sinonasal pathology and you're describing it either in the literature or you're describing it to colleagues, you all want to be talking the same language. So important relations. The middle turbinate has an intimate relation with the frontal sinus anteriorly, laterally the bulla and the uncinate. The superior turbinate, I do a lot of transphenoidal surgery, pituitary surgery, so I always come and find the superior turbinate when I'm looking for my sphenoid ostium. And the inferior turbinate covers most of the maxillary sinus, and if you do pediatric surgery, then the inferior turbinate can come right up to covering some of the orbit and lamina as well. If you ever see horizontal septation within the sphenoid sinus, then you know that this is a posteriorly pneumatized sphenoethmoidal cell or an anode cell, and so you can look for that. So it's important to have what you see on your imaging, and you try and reconstruct it and visualize it in your surgery. So we've got an Agenesi cell, and then any cells above our frontal cells. We've got posterior ethmoids. We can see the lamella going back and the sphenoid sinus. Here we can see the uncinate and the osteomeatal complex. Now, whether you do endoscopic sinus surgery as a functional operation or whether we do it for access, virtually 100% of the time we are operating through or within the osteomeatal complex. So it's really key that you have a deep understanding of the anatomy of the osteomeatal complex, and also then you have a plan as to what you're going to do to try and ensure that you preserve the drainage pathway of the frontal sinus, of the maxillary sinus and middle ethmoids. If you have an infraorbital cell or a Haller cell, this can obstruct your maxillary sinus drainage pathway, and it's important to recognize that, so that if you're doing an antrostomy, what you don't want to do is simply open the infraorbital or Haller cell and not actually open the true maxillary sinus. Here we've got a stack of frontal sinus cells above the agonase. So are these Kuhn cells? Are these anterior frontoethmoid cells? So again, have a classification and try and learn it and try and understand it, so that when you're communicating in publications or you're discussing these with your peers and describing the surgery that you've done and your findings, you're all discussing the same cells. Here we've got a frontal cell. Is this an anterior frontal cell? Is this a Kuhn 3 or a 4? Again, you've got to have a good understanding and a way of describing it. So other than the actual location of the cells, it's important to look for other pathology. And what's really important as well in functional disease is if there's any osteitis. So this is a picture of a gentleman with a frontocutaneous fistula. He's got pus pouring out from chronic left-sided frontal sinusitis. It's caused cicatrization of his upper eyelid and cataracts, and if we look at his CT scan, we are going to expect osteitis, and that's what we can see. So you can see here, this is the frontocutaneous fistula coming down over his eyelid, and what you're going to plan here is going to be potentially very different to if there wasn't osteitis, because once you have osteitis, the chance of it closing off and long-term results are much harder. So you've got to be really careful in identifying and describing the disease, so that when you come to your treatment plan, it's bespoke and precise for the pathology that you're treating. So this talk is primarily about how to try and visualize every scan so that you can try and bring together a 3D model in your head. And a nice way to do it is using the mnemonic close, where C is cribriform, lamina papyracea, orbits, anodi, optic nerve, sphenoid, and then the ethmoid arteries. So if we start with C for a cribriform, the depth of the skull base is key, as well as asymmetry. So what we want to do is to have a look at the preoperative scan, and if you've got a skull base that's very low and a Kiros that's 3 or above, then you know that anteriorly, as you come towards the frontal sinus in the fovea, this lateral lamella is going to be really thin, and that's the most common site for iatrogenic injury in endoscopic sinus surgery. Sometimes it's so thin that as you're looking at it, you can see the dural pulsations. So you've got to recognize that, and if you recognize it, then you'll pay more respect to it during the surgery. L is lamina. You want to check for dehiscence. So as you're looking at a scan, if you see a dehiscence of the lamina papyracea, you're wondering, is there an occult blowout fracture that's here. If this patient had extensive polyp disease and you went in trying to debride the polyps in the anterior and posterior ethmoids, it's conceivable that very easily you might injure the orbital contents in the medial rectus. So O is the orbit, the optic nerve, and a node cell. So again, you want to check for dehiscence. You want to look at a node cells, and you might argue or try and understand or question what's the significance of these posteriorly pneumatized ethmoid cells. So let's imagine that this patient had extensive mucosal disease, and we were doing an anterior to posterior ethmoidectomy. So in coming from anterior to posterior, as you're going through the lamellae, and as you go through the basal lamella and you enter the posterior ethmoids, you're going to come across an optic nerve that's almost free within this posterior ethmoid cell. And if you don't recognize that preoperatively, then you're not going to be looking for it. And this is just in your ethmoidectomy. So you've got to be clear as to why these posteriorly pneumatized sphenoethmoid cells are so important. We're operating more and more on the optic nerves, and if you have, as in my hospital, a big neuro-ophthalmology department, then sometimes they'll want you to take biopsies of the optic nerve, and if the anatomy allows it, then doing a biopsy when it's indicated through the sphenoid is much lower morbidity than a craniotomy or another approach. So here we've got a patient who's losing vision with what is radiologically glioblastoma multiforme, and the treatment's radiotherapy. It's a very horrible condition to have with a poor outlook, but you can see here, this is the normal optic chiasm, and we can see pituitary stalk and a very inflamed, enlarged chiasm, and we can see the optic nerve here compared to this side. And here, this is a transsphenoidal approach. This is the right optic nerve, and we've taken the bone of the canal away, and in this patient we wanted to get histological confirmation, which we did, and he then went on to have radiotherapy. So this can only be possible if you recognize that S is sphenoid skull base, and you want to look for dehiscence, because what you want to do is you want to identify areas that you're worried about, that you want to identify. So this is the carotid artery, and we're using Doppler and image guidance to find it, because what we want to avoid is this. This is carotid injury during transsphenoidal surgery for a pituitary adenoma. This was a functioning tumor. The sphenoid, you want to look to see whether you've got a conchal, a precellar, or a cellar. The majority, luckily, are cellar type pneumatizations, but if you've got a conchal, then expect it to be harder. It's not always like this. This is what we all enjoy, and this is the reason why we do endoscopic sinus surgeries, because the anatomy is beautiful, but it's not always like that. And if you've got a sphenoid like this, expect it to be difficult. Skull base, the slope of the skull base is important to recognize, and then the ethmoid arteries. So I always look for the ethmoid arteries in my pre-op imaging to try and look for this nipple between the medial rectus and superior rectus, just as the globe's disappearing. Moving on to MRI, so I use MRI for CSF leaks, for fungal disease, any intracranial complications of sinusitis and nasal tumors. So this is a lady who's clearly got a blocked nose, she's mouth breathing, and the eyes look as if they're pushed apart. And unsurprisingly, we've got a pathognomonic set of images. These are taken at the same time on the same day. We've got heterogeneous expansile mass in both paranasal sinus cavities with intraorbital extension, hypoattenuation on MRI. This is fungal disease. We don't need a biopsy. Treatment is radical debridement. Here, MRI is useful to look for confirmed CSF leak, but also to see if there's any meningocele or meningoencephalocele. So in this picture, we've got bony dehiscence. We've got a defect that we think is coming down, but when we look at the MRI, there's significant encephalocele, and this is one which we decided would benefit from a craniotomy because we were worried about frontopolar vessels that would come down and that we wouldn't control them if we were to resect this piece of brain. So MR is also useful for soft tissue tumours, and here we can see this is inverted papilloma, and in this T2 sequence that the papilloma is arising within the ethmoid cavity, going up in the frontal, and when we clear the sinuses, we should be able to pull it out so that it's not arising within the frontal sinus. So finally, we need to recognize nasal anatomy. We need to be aware of the landmarks, the variations. We need to be able to integrate the endoscopic anatomy with CT and build that 3D model so that when you're at surgery, you have all the septations that you're expecting, and you use your image guidance to confirm where you are, not to find your way. Use triplanar viewing software wherever you can. Thank you very much.